Hello, everyone. Welcome to AONM's second webinar with Professor Brigitte Koenig. We're delighted to have her back again. She was with us last April and introduced the first set of sort of more basic mitochondrial testing that we do with MMD laboratory in Germany. And now she's going to talk about the supplementary tests, which are also very important and interesting and useful. So I'll just introduce her briefly. Professor Koenig is a professor of medical microbiology and virology, infectious immunology, and infectious epidemiology. I will stumble over that word, sorry, epidemiology. She has degrees in biology, chemistry, and medicine, and a PhD in medical microbiology and infectious immunology. She's written 5 books and 9 book chapters, and also published 140 peer-reviewed articles as first author and 510 peer-reviewed scientific articles. Professor Koenig is the recipient of several prestigious awards, including a postdoctoral fellow award from the American Society of Microbiology. Today, she will be doing most of the webinar. I will, at the end, talk a little about how to address the specific tests that she'll be talking about. We will, however, be doing another webinar with therapy in greater detail because there is so much to say, hopefully with her attending as well. Please put your questions in the chat or the Q&A. And I would say, Professor Koenig, if you could just switch to the second slide, please. Next. If you could just take it to the second one. Yeah, just to say that the oh, it's a little bit unstable, isn't it, at the moment?
Yes.
Just if you just switch to the second one. Otherwise, I can always do it from my end. Does it switch there? Well, all it is the webinar from last year, which was part 1 on the second page, and that shows how to access it. Are you able to get to that, Professor Koenig? Yeah, super. So, Professor Koenig, you go ahead and thank you.
Yeah, sorry, no, it's not functioning. Do you see the slides?
Yes, go on to the next one. That's fine.
Okay.
I've introduced that one. That just shows
Wonderful.
the old webinar of yours. Thank you.
Okay, sorry. Okay, the mitochondrial testing with AONM is covering the ATP profile, the mitochondrial health index, the supplementary biomarkers, and later I will turning over to Gilian, which has an overview of therapeutic initiatives. At the ATP profile, we determine the total ATP, the mitochondrial ATP, glycolytic ATP reserve capacity, the mitochondrial health index. I think you know it very well, with the basal respiration rate, mitochondrial ATP turnover, proton leak, maximum respiration rate, reserve capacity, non-mitochondrial rate, calculation of the overall mitochondrial health index. And I will talk the first time about the supplementary biomarkers. It will be the ratio of mitochondrial DNA to nuclear DNA, or the mitochondrial mass, the PGC1 alpha expression, the NERV2 expression, a specific mutation, mitochondrial DNA mutation. It's a mitochondrial 4977 deletion mutant, and the lactate pyruvate index. Let us start with the ATP profile. I think you already know it. Here you see one typical result. It's not the best result for the patient. You see the total ATP. The total ATP is in the low range, so this person has at the basal state not enough energy. And if we look at the capacity to produce this total ATP by the mitochondria, we see that's insufficient. So it's more produced by the lactate. The reserve capacity is very important because it has two functions. On the one side, it says, is the cell able to produce energy by alternative pathways if the mitochondria are not functioning? And here we see that the reserve ATP capacity is very, very low. So here we have different points where we can start with the therapeutic, with the therapies. We look now at the mitochondrial health index. Also, you know this one. Here we have a result. It is totally, it's 11-page report, but here we only show the first page, and we see again more the mitochondria if they are under pressure. And please convert your or look at the maximum first, at the potential maximum oxygen consumption rate in picomole per oxygen per minute. It's here 62. That's very, very low. That the person is not able to produce a lot of energy if it is necessary or under pressure. And you see that is reflected also in the cellular energy phenotype on energy demand. Normally it should be energetic and aerobic. Aerobic means that mitochondria are used. Here you have a glycolytic phenotype. That means to get a little bit more energy, the person or the cells are producing lactate. And we see here also a non-mitochondrial respiration. That means that the oxygen is used in the cell by other oxidases, by other enzymes. And additionally, we have a low coupling efficiency. That means that a lot of oxygen radicals are produced at the inner mitochondrial membrane, which is also negative. The mitochondrial health index, there you can read, it was one part of our webinar. And also to the mitochondrial health index, there is an interpretation of these results. So it means that the mitochondrial dysfunction is really considerable. We have an upregulated reactive oxygen radicals in both in the cell and in the mitochondria. We have a compromised electron transport chain, a limited number of intact mitochondria, and insufficient ATP on demand. And if you ask always, yes, is it possible to cure the mitochondria or to cure the mitochondrial dysfunction? Yes, it is possible. Here you see one patient, and it is 3 different or consecutive measurements. They started on the October in 2020, then in May 2021, and again on June 2021. And you see that we have a consecutive increase in all parameters. So they're getting really better. And now in 2021, there was a maximum possible oxygen consumption rate of 180, and that is really good. And the reserve capacity, also on energy on demand, of 468%. It's much more than the target value of, or the optimal value of 400. So yes, if you ask again, is it possible to cure the mitochondrial dysfunction? Yes, it is possible. Now we go to the supplementary biomarkers. And there we go again on the ratio of mitochondrial DNA and nuclear DNA, and we will start with this parameter. Just remember that the mitochondria have their own DNA. Some DNA from the former mitochondria are now in the nucleus, but the mitochondria, or the own DNA of the mitochondria, is coding for very important proteins which are necessary for the ATP, also energy generation. So you see here the mitochondrial DNA, it's around 16,900 base pair. And you see that they are located genes for complex 1, for complex 3, complex 4, complex 5, and some additional for 16S and 12S RNA, also for processing proteins which are produced in the nucleus. And you can imagine that the mitochondria mitochondria have to interact with the nucleus to produce also all necessary proteins. As it's an interaction, a very network between the mitochondrial DNA and the nuclear DNA. It is, and if we determine the mitochondrial DNA and the nuclear DNA separately, then we can see how much mitochondria are in the cell. The cell nucleus has only one copy of DNA, and the mitochondrial DNA reflects how many mitochondria are in each cell. So we can look, it is the right one, or is the number not correct? And here we have a ratio of mitochondria to DNA to nuclear DNA. It is really the same as a mitochondrial mass. We have a factor which we can look. And yeah, so we can really determine it is okay. 202, also the ratio of mitochondrial DNA to nuclear DNA of 202 is in the normal range of the mitochondrial mass, which is present in immune cells. And what is the normal result we get with our patient? You see a ratio of mitochondrial DNA to nuclear DNA of 580. That is too much. And why is the cell producing such a lot of mitochondria? The cell is trying to counteract a lack of energy by increasing the number of mitochondria. So we can be happy that the cell is able to produce more mitochondria. This is to compensate. In the example 3, you see a ratio of mitochondrial DNA to nuclear DNA of 115. That is very, very low. And in combination with the mitochondrial health index, if it is very low ATP production, then at this moment, the cell is unable to counteract the lack of energy. So it is not anymore able to increase the number of mitochondria. So that is much worse than if the ratio of mitochondrial DNA to nuclear DNA is above the normal value. So then in this connection with the mitochondrial mass, the expression factor of PGC1 alpha, also it's, you don't have to keep it in mind, but it's a peroxisome proliferator activated receptor gamma coactivator 1 alpha. I think you forget it. You are allowed to forget it. Also the PGC1 alpha is central for the induction of new mitochondria. You see on the left side the mitochondria, and if they get a signal, then they produce PGC1 alpha. You see it on above, and then you activate, or the cell is activating mitochondrial genes, and you get more mitochondria. So the PGC1 alpha regulates mitochondrial biogenesis and has also an effect of mitochondrial functions. The other points are also important, but we only want to focus at this point on the production of new mitochondria. And here you see one expression example. It's an expression of 0.000953. Okay, you don't know exactly what that means, but we show you the interpretation. This measurement of relative expression in relation to a housekeeping gene shows that the PGC1 alpha expression is barely detectable. This indicates extremely low or absent new mitochondrial formation. And if this is in case of also if this is the case and the mitochondrial DNA and nuclear DNA ratio, also the mitochondrial mass, is too low, then initiative should be taken to increase PGC1 alpha. So this result you have to see always in connection with the ratio of mitochondrial DNA to nuclear DNA. Sorry, now there was a small. So now I want to switch over to the common deletion mutation, and this mutation is caused by oxidative stress. That is a mechanism which is which we know now that is really performed by oxidative stress. And what does it mean? It means that you have here again the total mitochondrial DNA of 16,970 around base pair. And if the oxidative stress is there, then the mitochondrial DNA is fragmented and this part is deleted. It is thrown away. So you have at least a mitochondrial DNA which has this part no longer inside. It's 4,977 base pair. Therefore, it is called the common deletion mutant. But if you look at this deletion, also this 4,977 base pair, you see that there are a lot of genes on it which produce proteins for the ATP production. So if you have such a mitochondrial DNA, then this kind of mitochondria are no longer able to produce ATP. And here you see an example. We have the deletion mutant. We express it in the kind of this relationship. That means you have only 1.10 to the high 6, also 10. You would say
to the power of 6.
To the power of 6. Thank you very much, Gillian. It's 1 million, yeah. 1 million normal mitochondrial DNA to 1 mutated mitochondrial DNA. And that that means here is too much of stress, of oxidative stress, so that you have really damage of the mitochondrial DNA. And then the question, what does it mean? Okay, in the blood, and here's an example of blood. In the blood, you see also a connection between your age and the number of this common deletion mutant. And it depends a little bit how you are doing your test. Here we are doing in this figure, we see really a clear, we see an increase with the mutation in age. And if we do a little bit less DNA, then we don't have an impact of the age. But what is here very important is this oxidative stress is not only in the blood, it is everywhere in the tissue. It is in the brain, in the heart, in the muscles. And in the brain, in the heart muscles and in the muscles, you have a post-mitotic tissue. That means it can't be replicated very well. It can't be regenerated very well. So this mitochondrial deletion mutant is accumulating. That means that at least about 50, 60, or 7% of your mitochondria in the brain is no longer able to produce ATP. Therefore, it is very important to always look at your mitochondrial DNA deletion mutant in your blood to see whether you have a high oxidative stress, which may damage the mitochondrial DNA everywhere in your brain, especially in your heart and in your muscles. So, and we have vicious cycles of reactive oxygen species production and oxidative damage. If we have an elevated reactive oxygen production, then we have an oxidative damage to mitochondrial DNA. If you have seen before, it's, for example, the mitochondrial common deletion. If you have this one, then you have the loss of mitochondrial DNA-coded proteins and RNA. You have seen that the mitochondrial DNA can't anymore longer code for the complexes. then you have a functional disruption of the electron transport chain. It's no longer to produce ATP, and that again leads to an elevated production of reactive oxygen species. So this vicious cycle we have to interrupt. Another very important point beside PGC1 alpha, also the mitochondrial mass, is now the NRF2, because if we have this mutation, you have seen that we have a lot of reactive oxygen species and that we have to combat. We have a nuclear factor, erythroid factor 2, related factor 2, NRF2. Again, this you don't have to you have to
to memorize it.
To memorize, thank you very much. To memorize this name, just remember that it's NRF2. And this is a very, very critical transcription factor that regulates the expression of over 100,000 genes in the cell under normal and stress conditions. That is always if there's oxidative stress in your body, in your cells, wherever, then NRF2 should be increased to combat this stress. Normally, this should function. We analyze the NRF2, and in this case, it was not detectable NRF2. What does it mean? The NRF2 has to protect your cells from reactive oxygen species. And if this NRF2 expression is not detectable, that indicates that you have extremely low or no absent defense against reactive oxygen metabolites in the cell. Might be you don't need this one because you are well. But on the other side, if you have, for example, a very high number of mitochondrial common deletion mutant, then it means that you don't have enough NRF2 activation. So you have to see there or to activate your NRF2 pathways. And here we see the combination. If the NRF2, therefore it's very important to compare this NRF2 expression with your MHI. Is there oxidative stress in the cell, in the mitochondria? That means if the NRF2 level is low or undetectable and the 4977 deletion mutant is elevated, it is vital to initiate action to support to endogenous antioxidants, NRF2 activation, that's very important, and exogenous antioxidants. And Gilian will give you an overview of these a little bit later at the end of my talk. So now we go a little bit to the role of pyruvate. Now we leave the NRF2 part and the PGC1 alpha part. Now we go to our lactate pyruvate index parameter. And please remember a little bit, you need energy. And the mitochondria produce ATP. And one very important pathway to produce energy is that you have glucose. It is uptaken by a transporter. And glucose is converted into pyruvate. And pyruvate normally should go into the mitochondria to produce a lot of energy. If pyruvate can't enter the mitochondria, there might be different reasons, then it is going to lactate. And lactate in muscles is producing a lot of pain. And at the moment, this way from glucose to lactate can produce very quickly energy, but not energy if you need more. So you can perhaps run 2 or 3 meters very fast on this way. But if you want to do like a marathon or want to be more fit for several hours, you need the way through the mitochondria. The pyruvate has to go into the mitochondria. So therefore, it's important also to determine the lactate pyruvate index And this index shows you what level of lactate is being produced by the mitochondria, both at rest and under pressure. And we can determine, independent of the index, we can clearly also see whether the cell is, for example, primarily using carbohydrates and preferentially converting them to lactate, or whether the cell is primarily using carbohydrates and partially converting them to lactate, or whether the cell is primarily using carbohydrates and transporting them into the mitochondria, or the cell is using carbohydrates, fatty acids, and amino acids, and the carbohydrates are primarily being transported into the mitochondria, or the cell is primarily using fatty acids as fuel. And from this index, we can also see whether the cell is functioning like it should function, or whether in case of immune cells, the cell at the moment is perhaps fighting against viruses, or whether there is a chronic inflammation or chronic infection. And here you see, for example, lactate pyruvate of 1.61. And as I mentioned before, this lactate pyruvate plus also gives you insight into what nutrients are being used as a fuel for the mitochondria. And here you see your immune cells are primarily metabolizing carbohydrates and partially converting them to lactate. But on inactivated cells, the cells are primarily using carbohydrates and converting around 80% of them lactate. That means at this moment, they are not able to use the mitochondria. And this buildup can be very painful, and it's like the fibromyalgia type symptoms.
Fibromyalgia.
Fibromyalgia. Thank you very much, Gillian. Perhaps I will learn it.
It's a difficult word.
Also, in former years, when I had a lot of talks at the American Society of Microbiology in the US, and then I trained my talks with the bus drivers always.
Oh, wow.
Yeah. Okay. So, and if I just go back to the number of, to the mitochondrial DNA and the mitochondrial DNA and nuclear DNA ratio, we have seen that it's very important. We extended now this test, and we figure out really the number of mitochondria in a cell, and we can now look at how much of the mitochondria are really intact and are non-intact mitochondria. And we think it's a very useful add-on to the simple mitochondrial mass, also the mtDNA to nuclear DNA ratio. So we can more look at also its therapeutic conditions or profiles.
Yeah, I imagine that would give us a good marker, wouldn't it, if one saw that gradually increasing the number of intact mitochondria over time?
Yes, and it shows again clear how is the relationship, a little bit more clearer results than before. Yeah, and then you said, okay, it's also important to screen for the mitochondrial oxidation, also the oxidation of the mitochondrial DNA, because that if the mitochondrial DNA is oxidated, we have not any longer intact ATP production. And as mentioned before, in the blood, where the cells are regenerated every 2 to 3 months, it might not be really so important, but this reflects the total mitochondrial oxidation everywhere in the body, and especially in the brain and in the heart muscles and in the muscles. And there it can't be regenerated because it's a post-mitotic tissue that is not regenerated very much. And so this is a very reliable marker for the mitochondrial oxidative stress. And you can monitor this one every 2 or 3 months and see that you don't have too high levels. You can do it in between.
Yeah, the difference between this one and the previous one that you told us about is that it's a finger prick test.
Yes.
So that makes it easier. You don't have to go to a phlebotomist or send it via courier to Germany in a more complex manner. So you can do this more regularly. I imagine for sports people who are possibly overtraining without knowing it,
yes,
that can be very useful, for example.
Yes, overtraining is a very big topic, and I had a lot of patients which think that they can cure them with a lot of sport, but they're doing the wrong thing. And here you can really screen it very fast or very regularly, and it can be sent by normal post here because the samples are stable for years. Yeah, so it's not a problem. Yeah, so I just remembered, or I just said again that we have an ATP profile, we have the mitochondrial health index, and in combination with the mitochondrial health index and with the ATP profile, there are some supplementary biomarkers which are very useful. It was a ratio of mitochondrial DNA to nuclear DNA, the PGC1 alpha, also that means how much mitochondria can be formed, the NERV2 as an anti-stress factor, the mitochondrial deletion mutant, which shows you how much oxidative stress you have in your tissue, and the lactate pyruvate index. And now I'm turning over to Gilian, which shows an overview of the therapeutic initiatives.
Thank you. Because you have the master, if you could turn to the next.
Aber sure.
Please. Thank you. So we'll just be talking about initiatives, and also only very broadly because of the time, that you can take related to those specific tests that Professor Koenig has explained previously. Of course, there are, and I see already one of the questions in the chat is what to do if you have mitochondrial dysfunction. There's a much broader approach, which interestingly we did actually go into in one of the talks on the past webinars, or if you look under the mitochondrial testing on AONM on their website, then you can see that there is a webinar on therapy for mitochondrial dysfunction, which we did right after Professor Koenig's first talk. So that could be very helpful in a more generic way. But if you find that you have too few mitochondria and your PGC1 alpha is undetectable or very low, as shown here, then there are various things you can do specific to that. Because obviously very few mitochondria will produce very little ATP, and you do need ATP not just for your energy, but for organ regeneration and for keeping so many signaling functions in the body going, and for all sorts of synthesis. Even synthesis of the blood is controlled by the mitochondria. So it's absolutely vital. And you will find that there are supplements, though we won't be mentioning any names here, but there are specific supplements that combine several of these together. So if you're the kind of person, or your patients are the, can tolerate synergistic supplements and not just one particular nutrient or nutraceutical, then you will find that there are products out there, and often the name even gives it away. But theoretically, that's not permitted by the EU. So some of the supplements have rather opaque names, and you just need to look at the ingredients. So resveratrol is particularly well known as a PGC1 alpha activator. And please don't get that from red wine. You would never be able to drink enough red wine to get, you'd be drunk before you got the resveratrol out of it. So Japanese knotweed, interestingly, even though it's considered to be a real, weed in England, but actually it's got this huge, characteristic of being able to do this as well as fight pathogens, interestingly. And so that's very, very beneficial. L-carnitine has this property as well as others, like getting fats, fatty acids into your mitochondria. EGCG, the extract from green tea, and various others here. I won't read them all out. Niacin, which is B3 in a particular form, particularly the kind that causes a flush, is known to help. And PQQ, only more recently discovered, that mitochondrial nutrient, which has now been found as an extract, is helpful, and quercetin. So we do have full evidence, good scientific evidence, many of them peer-reviewed, placebo-controlled trials. So, we can provide you with those if you like. Alpha-lipoic acid in the R form is also very good at doing this, as well as ellagic acid, which you can get from berries. These cyanidin-rich fruits too. I mean, often it's nice to say to patients, just eat these fruits, here's a list, or eat these polyphenols, here's a list of the herbs and the vegetables and fruits that contain them. But often very fatigued patients who don't have a partner who can just go out and do the shopping for them, come back and prepare the foods for them, even the smoothies, find it very, very hard to extract what they need from food. So it can be useful, certainly in the first instance, to obtain these from nutraceuticals, herbs. And Ecklonia cava, which is a brown seaweed with very special flavonoids in it, is useful here, as well as curcumin. And then next, please, Brigitte. If too many mitochondria are damaged, then consider mitophagy. What mitophagy means is clearing the debris of those dysfunctional mitochondria and recycling what can still be used. And often you'll hear autophagy, which is doing the same with cells, is hugely important for recovery. But one aspect of this that Professor Koenig has emphasized to me is that if you're just focusing on autophagy and not on mitophagy, then you may be clearing healthy mitochondria while you're getting rid of the unhealthy cells. And because cells do contain huge numbers of mitochondria very often, interestingly, in the substantia nigra, which is responsible for producing our dopamine, we have, I think, 2 million mitochondria in a healthy axon. So you can imagine you don't want to just be getting rid of cells if there are useful mitochondria inside. Of course, we can't be like little robots, picking out exactly what to eliminate and what to keep. But there is excellent research out there. And this is one tremendous article. All the references will be available on the slides that you receive, showing that particular items, some of them overlapping with what we've just discussed, are able to help with that mitophagy. In other words, that turnover of unhealthy cells to produce the healthy ones again. And the list here includes a few new items that we haven't yet talked about, like berberine, for example, sulforaphane, which comes from cruciferous vegetables, and various others. Curcumin and resveratrol, as you'll see on the right, have the most pathways responsible for this. So if you want to go for something that does both what we've just discussed and the mitophagy, then resveratrol and curcumin would be ideal, really. The next, by the way, it is important to look and see whether you've got could you just go back again a moment? On the right, you see, thank you, Brigitte, the limited number of intact mitochondria. If you have a limited number of intact mitochondria combined with too few mitochondria, in other words, many of them are damaged, be a bit cautious about going gung-ho with mitophagy. Wouldn't you agree, Brigitte?
Yes.
You can't be, getting rid of mitochondria too rigorously if you don't have many of them. So just kind of with your therapist or sort of thinking about that carefully, do tread very gently there. You can get worse before you get better, and that may not be a Herx reaction so much as really quite damaging for your cells. So long fasts and so on. Would you agree, Brigitte, as well, that,
yes.
that a very significant fasting, maybe just water fasting and so on, you just have to balance that against the state of your cells, ideally, in your mitochondria. Can you go on to the next, please?
Yes.
Interestingly, where autophagy is concerned, traditional Chinese medicine has known the importance of this for centuries, and we're only talking about that. Well, I say we, many people have looked into autophagy and the importance of it for ages, but it's become particularly important recently because the last 3 years, almost every scientific study has been done on COVID, and it's been found that SARS-CoV-2, the infection that causes COVID, actually prevents the two kind of components of the cell that you need for autophagy from being able to merge, the phagosome and the lysosome. And so it's particularly hard to trigger this with COVID. And so there's been a lot of coverage of this. And in the course of that, what's been found is that many viruses in particular do the same thing. EBV, cytomegalovirus, varicella-zoster virus, they all do that. They all disable autophagy in our cells to a certain extent. So Chinese skullcap is something mentioned here. That's the extract of that is called bakelin. That's a very valuable herb. Licorice, ginkgo biloba, Artemisia annua. It's been used in Eastern countries, in India for centuries. Very, very valuable. And then ginger too. I'm just mentioning the ones that we haven't already talked about. Can you go on, please?
Yes.
Brigitte? So if you have high oxidative stress in the mitochondria, again, if possible, check your NRF2 activity, because if that's ticking away nicely, then you will have endogenous components of your cells being produced naturally, like superoxide dismutase and catalase and glutathione peroxidase. But if you don't have enough NRF2 activity, or if you have huge oxidative stress showing evidently in your results, then you'll need antioxidants exogenously. In other words, you'll need to provide them from outside the body as well. And there are many antioxidants that you can use. It's just important not to, again, overdose on antioxidants, because the signaling properties of oxidants are very important. Brigitte, we've lost your picture for a moment, but would you agree that the signaling properties of cells that are, of the oxidative cells are also very important, aren't they? That's actually how the mitochondria work, is the interaction between oxidation and antioxidation.
Yes, that's very...
And so you can't completely kill off all of your oxidants either. So it's a very, very, gentle pathway that you have to tread. But what you can consider is, for example, next, please, the flavonoids, for example, listed in this absolutely superb article that will be evident when you receive the slides. I'm sorry that the sources are a little bit cut off, possibly in your view, but this article and many others go through the chemical properties of flavonoids of different kinds, the flavones, the isoflavones, the flavonols, and the anthocyanins, which are the red, purple, and blue colors in flowers, seeds, and fruits. They all have hugely important antioxidant properties. And it's due to their biochemical structure. It's very fascinating to go into that, and we will do in a further webinar. So the flavonones, for example, citrus fruits, all have, as you know, it's not just vitamin C, there are lots and lots of antioxidant properties as well. So please go on, Brigitte? Other antioxidants for which there is good evidence are, for example, acetyl-L-carnitine and alpha-lipoic acid, ginseng. So you have to be a little bit careful about that because that's very excitatory as well. CoQ10, of course, vital. Vitamin C, melatonin, lactoferrin, ideally in this form apolactoferrin, which has particular properties that we can talk about another time. It doesn't contain iron, which is helpful. Melons do contain superoxide dismutase. So, you know, of course you can obtain all of this from food, and the picture below does indicate that. But again, it's managing to obtain those antioxidant properties without going too high on your calories that are from carbohydrates, because as you'll know from Dr. Sarah Myhill's talks that we've had on AONM and many, many other sources, it's a very good idea, because mitochondria love fatty acids, as Professor Koenig explained earlier. You know, you have low lactic acid and much higher pyruvate and much better mitochondrial access if you're feeding your cells with fatty acids, if they can get into the mitochondria. So you don't want to be overloading with the carbohydrates from fruits and vegetables too much. So again, getting these in extracted forms if you need high doses for a while is definitely a good idea. And glutathione, of course, vital. All the foods below actually contain glutathione in different forms. Can we go on, please, Brigitte? Just briefly, and this is a huge, huge topic. If there's too much lactate evident in your test, that'll be because not enough of the pyruvate is getting through into your mitochondria and into the what's called TCA cycle. It's often also called the citric acid cycle or the Krebs cycle, which turns like a sort of water wheel and then produces metabolites for your electron transport chain, which is present in your mitochondria in thousands of copies. It's not just one. So it's a very, very complex process. And what could be stopping the fuel from getting into your mitochondria? If you have on the mitochondrial health index, MHI, a non-mitochondrial respiration marker that's higher than 10, because it should be below 10%, then that's a sign that the oxidases in your cytosol, which is here, in other words, the sort of bluey bit around the mitochondria in the cell that contains all your other organelles. If the oxidases there are high, they need to use oxygen in order to attempt to eradicate infections or heavy metals or other contaminants there. So that can be a sign. Wouldn't you agree, Professor Koenig?
Yes, I
that can
agree.
be the reason. That can be the reason why you have a level like this. It's not always red. It may be orange or brown, but anything over 10%. In other words, if more than 10% of your oxygen is being used outside the mitochondria and not inside, then that's an alarm signal that something else needs looking at. So if you could just go on, please. Next, yeah. You may simply not have enough of the right nutrients to get into the mitochondria, and B vitamins are particularly vital. It's not the only vitamin that you need or nutrient, but they are crucial. And that's all the Bs really, B1, 2, 3, 5, 7, that's biotin, and 12. And there can be methylation issues that stop those from, stop that wheel from being able to turn as it should. But could you just turn to the next page, please, Brigitte? Because B1 is particularly important. That's thiamine. You actually can't make mitochondrial energy without it. And I know this picture looks complicated. There is a very, very brilliant couple of doctors who've recently written a book about thiamine deficiency and the huge importance of it for energy production. One of them is called Chandler-Mars, and then I think Dr. Lonsdale together with her. And it's something that hopefully will summarize and perhaps even have them to speak at a future webinar of ours. But what's important is that this entry gateway into this all-important little cycle that produces the energy in our mitochondria can get blocked. And one of the, it's called the pyruvate dehydrogenase complex, and that is dependent on thiamine. That's B1. And so if that's blocked, then your lactate will go up. And there are many, many things that can block pyruvate dehydrogenase complex. You can see some of them here. One of them is the B1 deficiency, but because B1 is dependent on manganese, it can be, magnesium, it can be because you're not getting enough magnesium. Hyperglycemia can do this, of course. Insulin intolerance, when you're unable to actually activate your insulin and take in your glucose into the cells, the wrong kind of diet, tobacco, and of course, very importantly, most pharmaceuticals will have an effect on that. And we have an entire list of them that we could give you. And of course, unfortunately, antibiotics, don't they, Brigitte? Antibiotics have a huge impact on the mitochondria, don't they?
Yes, as antibiotics are very important, and we are glad to have antibiotics available. There's no doubt about it. But if you use antibiotics, sure, they also inhibit mitochondria. And if you use them, also it's not necessary. That is the problem.
Yeah.
Not only mitochondrial dysfunction, but also the generation of a lot of antibiotic resistance. And if you really need it, then you don't have available antibiotica.
Yes, and of course there are certain antibiotics that just should be avoided at almost any cost, like the fluoroquinolones, ciprofloxacin. Though again, sometimes doctors say they're needed and there's nothing else that will work. And then there's heavy metals, which I have mentioned, particularly arsenic, mercury, and aluminium will block this PDC, the pyruvate dehydrogenase complex. Can you just go on to the next page, Brigitte, please? So the cell danger response, and I saw there was a question in the Q&A about that too. We'll simply need another session on that, I think, because it's much too big a topic, but that can switch the activity of the mitochondria to a so-called protective response, where they're not using the oxygen, they're pushing the oxygen into the cytosol to conduct this battle, this fight against pathogens or heavy metals or contaminants in there that need to be eliminated. So a wonderful article by Professor Navio is referenced at the bottom of this page, as well as a summary of it that I've made that is easily accessible. Could you go on, please? So just to mention before we go on to questions, we do have some upcoming webinars this month. Professor John Lambert's webinar 2 weeks ago was so incredibly popular that we had hundreds of questions also coming in afterwards. So he's agreed to come back again on the 14th of March to answer those questions. So that'll just be a purely Q&A session. Dr. Craig Shimazaki from the States, from Oklahoma, will be talking about how pandas, as they're called, these sort of autoimmune reactions that can cause, it's infection-triggered neuropsychiatric conditions, really, how they are being influenced by the strep A that's currently circulating, the RSV infection and influenza. So that will be fascinating. And then Dr. Garg from Finland will be talking about a new test that AONM is introducing, a mycotoxin test from blood. So that's on the 30th of March. So that's it, Brigitte, I think. Could you just turn to the end? Yeah, so we have a couple of slides after this that describe Professor Koenig's background and her laboratory. We won't go into them now, and also a slide showing the seahorse XF technology that she uses that is widely used around the world for peer-reviewed studies, 7,600 at the last count. So let's go to the questions, shall we, Brigitte?
Yes.
Thank you. I'll just ask a few of them from the beginning. What type of ratio of mitochondrial DNA to nuclear DNA would you expect to see if the cell was in this cell danger response where it's switched and not using oxygen in the mitochondria? Is there a connection between the ratio and that?
Yes, it is in a very early cell danger response. The mitochondrial to nuclear DNA is increasing to compensate.
Oh, that makes sense. Yes. And then a question about how to activate the NRF2 pathways. I hope that was partially answered at the end there, but we will be having a separate webinar on the therapies. Let's focus on the testing for now. Is it possible to test mitochondrial function in detail using saliva or urine?
Saliva or urine? Yes, it is possible. But if you use saliva, it's okay, but it's a different type of cells in comparison to blood cells. Saliva is for people you know it, or for experts, it's more also on brain. So you can do it with saliva cells. Yes, that's possible. With urine, it's more the epithelial cells. So it depends what do you want to know. The immune cells in your blood are circulating through whole the body, and they look signaling what is in the body. And if there's too much oxygen stress or whatever, they also will get this one. And in addition, the blood cells signaling infection or chronic disease and so on. The urine cells are special in the urine. They are specially epithelial cells. Perhaps they are infected, but it's a different question. So urine cells, I don't find them very useful. Saliva, that is another point. That could be interesting. Yeah. But they are not circulating in the body. Yeah? So it's only what is just in this tissue, but not everywhere in the muscles or somewhere else.
Understand. Thank you. Is the finger prick test for mitochondrial oxidation as comprehensive as the blood test?
Yes.
That's interesting. Thank you. Which test result would indicate that one may or may not benefit from taking urolithin A, which is, of course,
yes.
That's good for mitophagy, interestingly.
Yes, yes. Also you mean which blood test is which blood test?
Which of the tests? I mean, I'm imagining that it would be because it's good for mitophagy.
Then it would be the MHI in combination with the PGZ1 alpha and the mitochondrial mass. Yes, unfortunately, all three.
Thank you. To what extent are tests done on PBMC, that's the immune cells, representative of the condition of the mitochondria in other tissues, e.g. muscle?
Yes, there are a lot of papers and we have to decide a little bit. Yes, the blood cells circulate everywhere. And if the blood cells are in bad condition because they see there's the environment, there you have heavy metals, then also your muscle cells will also be damaged, or the mitochondria in your muscles. And there are some very good papers also and studies which have shown that if people around 60, if they start to do sport and so on, that if they have an increase in the mitochondrial function in the blood cells, then also there's an increase in the mitochondrial function in their muscle cells because they did biopsy. But now I say, please consider, if you are a very sportive men or women, then your muscle cells will produce a lot of mitochondria, huge amount of mitochondria. So you can do a lot. And if then the mitochondria are a little bit dysfunctional, sure, you will see that you are not perhaps not so good as before, but in comparison to other people, you are wonderful fit. Yeah. So because the huge amount of mitochondria will compensate the mitochondrial dysfunction, your blood cells have not this amount of mitochondria. They have only 60, 70. So if you have there the dysfunction, you will see it very fast because you get infection or they can't fight tumor cells. So sure, so you can say if you have bad mitochondria in the blood, it will also be in all tissues bad, but you can't exactly know how much of them because it depends on your how you are living, how is your lifestyle, did you a lot of sport and so on. Yeah. Yeah.
Thank you. You've answered the second part of the question to a certain extent, which is, would you expect the same result on a muscle biopsy? The next question is, I suffer with fibromyalgia symptoms. Could this be down to my lactate levels?
Yes.
Yeah. And then the second half, which is, how do I try and correct this? Again, we'll be covering when we look more at the therapy. If the cell was using aerobic glycolysis, would you look to downregulate the PDK, that's the pyruvate dehydrogenase kinase expression? Again, this is more therapy, really. Perhaps say pass on this one and we can address this the next time.
Yes.
That's more cancer, isn't it, really? Or would you look to address HIF, that's the hypoxia-inducing factor 1A? It's a difficult one, isn't it? Because it depends on so many other factors.
Yes, with regard to the pyruvate dehydrogenase kinase, we are doing the MHI in our additional experiments, and we add activators of the kinase and look whether there's different than response. So you can exactly see whether that is the problem or whether it's not the problem. Yeah, so it's possible to address these questions by analytical, by a little bit by the MHA with some corrections or some additions.
Another question here, and then I'll go on to the Q&A. We won't go on for a long time. So I think, Brigitte, what we'll probably need to do is the same with you as we did with Professor Lambert, which is to request that you come in just for Q&A another time, because we literally in both chat and the Q&A have so many questions.
Okay.
It's impossible to cover them all now. Another interesting one is, how were the reference ranges devised that you are using in your tests?
How is the
reference ranges?
Yeah.
Where do they come from?
Yeah, that is a very, very good question. And because the reference are not from ill patients. We screened a lot of literature with specific diseases. We had our own people with sports people, with people around students, a lot of students, and sure also ill patients. So sure, it might be that we have sometimes to correct it a little bit, but not too much. Yeah, and then we did sure also statistics and so on. But we did not use the data only from our patients, because that would be don't reflect the correct reference values.
Okay, thank you. Yes, we can maybe put up some information about that on our website, can't we? Or in the tests. Do you have any experience of whether the presence of mercury can disrupt the mitochondria?
Also we jetzt personally did not analysis, but if you add some mercury, thimerosal, yeah, to your cells, then they will function anymore. And I think there are a lot of literature which indicates this.
Okay, thank you. And for the advanced test, if they are done without ATP, and that's the ATP profile and the MHI, do you still require a shipment within 48 hours from the blood draw? I think what is meant there is, do we need to do the MHI with all of the advanced tests? I know we don't always need to do the ATP profile.
Also, perhaps I misunderstood it. Also
the supplementary markers.
Yeah, the supplementary.
If you could just go over which of those you must do the MHI for as well, and which of those can be done independently.
Yeah, also you can the MitoOx, the new MitoOx test, just to screen whether you have oxidative stress level and DNA damaged, also mitochondrial damaged DNA. But you can't see from this point alone how the mitochondrial function is. So perhaps if you have the MHI, and then you can do the follow-up with the MitoOx test or only the MitoOx test. The other, the mitochondrial nuclear DNA, also mitochondrial mass alone says nothing, yeah. So
when you say that there is nothing, do you mean that it doesn't mean much alone, or do you mean you cannot do it without the MHI?
No, I can do it alone. I can do it, but I can't interpret the results really well, yeah. That is the problem, yeah. I can do it. Also we can do without the MHI and without 48 the MitoOx, the mitochondrial deletion mutant, the mtDNA to nDNA. We can also do, but then we have to change a little bit Gilian. Then we have to do it on blood, on dry blood. There we can go look at the PGC1 alpha and then the NERV2.
So what we are doing, and this is another question, is whether all the tests will be available to order, including the additional finger prick tests soon.
Yes.
The intact versus non-intact mitochondria is already available to order. We just need to sort out a couple of small points, like adding that to our order form. But the finger prick test, we're just in the process of assembling the kits properly for that, in association with Professor Koenig. So that will probably take a couple of weeks. I don't imagine it'll be longer.
Yes, and this type of test you can just put into the post, and they are stable for months, for years.
And then another question is, where can we find the test prices along with the turnaround time? The turnaround time depends a little bit on how extensive the test is. The measurements are actually made quite quickly, the analysis, because it needs to be done on the fresh blood, apart from the finger prick tests. But the interpretation and the translation into English, and the also combining the different tests in order to see what the meaning of one is in relation to another, that can take Professor Koenig a little bit longer. So it's between 2 and 4 weeks. I think we'll need to probably close up at 10 past, because people were only expecting it to be an hour. So if you bear with us, we will arrange a follow-up webinar where we divide these questions into test questions and therapeutic questions. I think that would be appropriate, because there are quite a few here. What's the cost of the tests as mentioned? The form is up on the website, and it's under the mitochondrial testing, and I believe the prices are there on the form as well. If not, I'll ask afterwards for the cost to be sent out together with everyone who registered for the webinar, together with the recording. And people are asking, will the recording and the slides be made available? Yes, absolutely. Last question perhaps for now, and then we'll go into, as I say, the ones relating to nutrients. The action, I can see one here, can B vitamins upregulate the energy process in the same way as 5-MTHF upregulates the methylation cycle? Let's go into all those more complex questions in the next session and talk about, here, just one last question. Can you confirm that the test can examine mitochondria of our white blood cells?
What?
Can the test examine mitochondria of our white blood cells?
Over white blood cells?
Of our von den weißen Blutzellen.
Yes.
It's exactly what it examines, isn't it? No, I just wanted that clarification. That is what's being examined. It's not the red blood cells. Red blood cells, erythrocytes, are actually the only cells in the body that don't have mitochondria. That's true, isn't it?
One moment, I was now looked at another question. The peripheral blood mononuclear cells are the blood cells, are the white blood cells. They are composed of monocytes, of lymphocytes, and T and B cells. But we can also separate them. And if somebody is interested only in the CD8 T cells in connection with cancer, then we can also look at individual cells. But at the MHI, totally, we take the peripheral blood mononuclear sites, the lymphocytes, yes.
And you are able to only look at the thrombocytes, for example, the platelets.
Yes, the thrombocytes.
And that's fascinating because...
Yeah.
Yes. Yeah. Again, let's maybe keep that in mind and explain the next time why taking just the thrombocytes is interesting.
Yeah.
So thank you so much, everybody, for being here and all of those questions. We will make a record of all of them, separate them out, address them, hopefully soon. I'm sure that'll be like the beginning of April or something after Easter. And please send in further questions if you have them, and we'll add them to the list. And thank you so much, Professor Koenig, for your expertise and your wonderful tests and for being there with us this evening. Thank you.
Thank you very much. Good evening to all. Thank you very much for hearing.
Thank you.
Bye-bye.
Thank you. Bye.